Next up, I'd like to present Heather Walsh. She will be presenting on hypermobility in young athletes. She's a physical therapist at UCSF who cares for children with musculoskeletal and sports injuries. She earned her Master of Physical Therapy degree at Samuel Merritt University, and she is also a certified stop Pilates instructor. She's dedicated to helping kids return to their sport or any type of physical activity with a special interest in working with athletes from dance, gymnastics, and figure skating. So help me welcome Heather Walsh.
Good morning. Today I'll be talking about hypermobility as well as hypermobility in the athlete. I have no disclosures. Here's the course description. And these are the course objectives. So hypermobility, what is it? Is it an asset or an liability? Hypermobility is the capability of a joint or group of joints to move passively or actively beyond its normal limits along physiologic axes. Having hypermobility is not always clinically relevant. Think of the gymnast who presents with hypermobility but does not report any subluxations, dislocations, or pain. They do not necessarily need to be medically managed. What is clinically relevant? In the hypermobile patient, their joints are stabilized by their active systems, their muscles, their tendons, along with adequate proprioception. However, their passive systems, their fascia, ligaments, joint capsules are often inadequate. So the hypermobile patient may not always present with instability if their active systems are strong and basically doing their jobs. So when I was doing my research on this topic, it was really interesting. In 2017, an international consortium on Ehlers-Danlos came together and they updated their classifications and terminology used to describe hypermobility-related conditions. And the joint hypermobility syndrome or benign joint hypermobility syndrome is an outdated term that should really no longer be used. Asymptomatic hypermobility can be used to describe those patients that have hypermobility, but they don't complain of any pain or functional loss. So most of our patients will fall into the symptomatic hypermobility category. And this is obviously hypermobility with pain or another complaint. And the consortium came together to also create a new term. It's called hypermobility spectrum disorder, also known as HSD. And these are the patients that we'll see that do have the symptomatic joint hypermobility, but they do not meet the criteria for Ehlers-Danlos syndrome. The majority of our patients will fall into this HSD category. And it's important to note, in order to be diagnosed with an EDS, or technically it's called hypermobility EDS, they need to meet 3 criteria, which I'll discuss a little bit later on in this presentation. So the prevalence was very difficult to find a good number. The research varies quite a bit. So anywhere from 2 to 57% of the population is suspected to have hypermobility. More specifically, about 10 million people in the United States and 255 million people worldwide. So what are the limiting factors for coming up with good prevalence numbers? Clinical assessment methods. There's been various clinical assessment methods done in different research pieces. Also, the nomenclature has been inconsistent. So hopefully with this new definition of terms, that the consortium came together to include, then that will solve that problem. Cutoff scores have been variable. The population that they've been studied, so some people have been studying athletes, some have studied non-athletes, so it's not very consistent. And then physical fitness, age, sex, and race all come into play. As far as sex goes, it is greater in women than men, usually a 2-to-1 ratio. There are some studies that suggest higher prevalence in certain races, such as African, Asian, and Middle Eastern. And then age is a big factor. So obviously we see this more in children, anywhere from 5 to 40% of children, and usually more about 10 to 20% in adults. It is important to note that hypermobility does decline with age. So in the 20 to 30 year old range, it's about 34%, and 60 and older, about 18.4%. And that's just as our joints change and we become less flexible. So what is the etiology of HSD? It's currently unknown. However, it's unclear if it is a genetic disorder or not. It is suspected to be an autosomal dominant trait, and also related to genes encoding collagen or collagen modifying enzymes. It does tend to run in families, but more research is needed in this area. So contributing factors for hypermobility would be decreased strength, impaired proprioception, hormonal factors, bone shape. Think of the patient with a shallow trochlear groove that has frequent patellar subluxations or dislocations. Acquired for trauma, you can think of maybe the wrestler who gets thrown to the mat and has a traumatic shoulder dislocation. Joint disease, and then sports training. Example of that would be the baseball player who has excessive range of motion in their dominant throwing arm versus their non-dominant arm. So to describe a little bit more about symptomatic hypermobility and the hypermobility spectrum disorder, they came up with 4 different categories. And generalized is when you might have hypermobility throughout all joints. Peripheral would be limited to hands and feet. Localized would be a single joint or group of joints. And historical is when the patient describes that they've had hypermobility in the past, but they no longer have it on exam. I wanted to include this slide. EDS or Ehlers-Danlos syndrome is a whole different topic, but I wanted to include this slide because it does show the 13 different subtypes of EDS that they have, that the consortium has reclassified. And you'll see in there, hypermobility EDS does exist in those classifications. So to the right of this slide is just a simplified criteria list of the 3 different criteria categories that must be met for your patient to be diagnosed with an HEDS diagnosis. So what are the symptoms that a patient may present with? Recurrent joint subluxations or dislocations, joint pain and loss of joint function, joint damage such as cartilage tears, early joint degeneration, soft tissue damage and injury, recurrent persistent chronic pain, decreased proprioception, and decreased balance and poor coordination. And then they may also present with other medical concerns such as fatigue, autonomic dysfunction such as POTS, headaches, GI problems, and anxiety disorders. And a lot of times the anxiety disorders are fear-based. These patients have had other dislocations or they've had pain with movement, so they have a lot of anxiety generated from that. I thought this was a nice slide to kind of recalibrate how we think about HSD. The top one is how people tend to think about it as a mild, moderate to severe case, but really it's a spectrum where any of those symptoms can occur within these patients, and it's not necessarily mild or moderate or severe, it's just more of that spectrum approach. So how do we diagnose HSD? It's really a diagnosis of exclusion, so if they do not fall into any of the EDS categories, then they would most likely fall into the HSD category. There's currently no genetic tests available, and 5 years old is the minimum assessment age that they recommend trying to assess for hypermobility, and that's due to insufficient bone maturity. Some conditions that you want to be aware of to also rule out besides the EDS conditions would be other heritable connective tissue disorders such as Marfan's, osteogenesis imperfecta, Lewy-Dietz syndrome, Stickler syndrome, and skeletal dysplasia. You also want to rule out autoimmune rheumatic connective tissue disorders such as lupus and RA, chromosomal conditions such as Fragile X, Kabuki, and Down syndrome, and then any neuromuscular disorders that can cause joint instability such as MS or other myopathies. So I recommend the Ehlers-Danlos Society website page. There's a lot of good information for patients and also for clinicians. This can be found on here. This is a form that can kind of work through going over those 3 criteria in a little bit more detail. This is more for pediatric HSD, but that's going to be most of the times you see HSD in patients is in the younger ages. And then there's also one for HEDS. Again, this can be found on the website. It can also be found in the article by you et al. That I have in my references. So what are the diagnostics tools available that we can use in the clinic? Unfortunately, there's no assessment tool that has been validated for under the age of 5. And again, this goes back to infants and toddlers not having sufficient bone maturity. But one of the most common and most widely used screening tools is the Baton scoring system. It's considered to be the most reliable and valid in measuring joint hypermobility. And some more of the pros would be it has age-related cutoff scores. It's been validated in children. There's a study by Smits-Engelman in 2011 that proved it to be a valid tool for assessing children. And again, that's over the age of 5 though. It's quick to perform, only requires a goniometer. And the cons of this test is that it does not include assessing the upper and lower extremity joints, which is usually very common. The shoulder is one of the most common dislocations in the patellar femoral joint, so it does neglect to assess those joints. So here's a nice just visual on this test. It's important to note that the first 4 tests, you get 2 points for each limb that you assess. The first one is assessing the 5th digit to 90 degrees hyperextension. The second one is, can you bring your thumb to your forearm? And then your third one is elbows. Can they get more than 10 degrees of hyperextension at the elbow? And then the knees, can they also get to more than 10 degrees of genuine bottom at the knee? And then finally, the last one is a 1 point for, can they bring their palms to the floor and touch the ground without bending their knees? So there are some other diagnostic tools out there that are specifically testing for the extremities. The upper limb hypermobility assessment tool is a 12-item test. It does have a suggested cutoff score of 7 or greater. The specificity is 77% and sensitivity is 84%. The pros is that it does assess, like I said, more of the upper limb in multiple joints, but the cons would be that there's no age or specific sex cutoff scores. It's been only validated in adults, and it's definitely more complex and requires more skilled handling, so you can see it's a lot more involved, and it does take more time. So just as there's a tool for the upper, there is a lower limb assessment test, very similar, and that is a 12-item test, same cutoff score. It has the specificity of 86% and sensitivity of 68%. Similar pros and cons. It does assess the lower limb in multiple joints. No specific age or sex cutoff scores, only validated in adults. And again, it's more complex, so you can see it's another involved test and will take more time. So the working group on the International Consortium of Ehlers-Danlos syndromes, they've been doing an audit on these 2 tests. They're trying to figure out if they can pull specific parts of the test to see if that could be helpful to adding to the Baton scoring to make it more encompassing of all of the limbs as well. But that's in process, and they're currently, they don't have a solution yet. Okay, and then finally, as far as diagnostics tools go, there's the 5-part questionnaire. This is a very quick, simple tool that can be done even before the patient enters the clinic room. It is a positive score of 2 or more, has a sensitivity of 91% and a specificity of 75% to assess hypermobility. It's easy to administer. However, it is only valid in adults, and it does not provide information on individual joints in the limbs. So there's a crossover to the Baton on this one. As you can see, it asks if you're double jointed. Can you now put your hands, could you now or ever put your hands flat on the floor without bending your knees? Can you touch your thumb to your forearm? As a child, did you amuse your friends by contorting your body into strange shapes? Or could you do the splits? And then as a child or teenager, did your shoulder and kneecap dislocate on more than one occasion? So how do we manage these patients? And a multidisciplinary approach is crucial. So if your patient presents with any joint damage or joint issues involving your orthopedic specialist, most likely these patients have some persistent pain or chronic pain, and they may benefit from seeing a pain specialist. The physical therapist, which I will go into more detail, can be very helpful in providing a role for helping with strengthening and patient education and joint protection guidance. And then oftentimes needing a mental health specialist to help manage pain and other symptoms. Somebody who's skilled in biofeedback or cognitive behavior therapy would be very beneficial. But when you're seeing these patients in the clinic, it's important to promote proper joint alignment and joint protection, proper posture, proper nutrition, And then also helping them maximize their functional ability and quality of life is key. Some less studied management tools that were mentioned, but more research needs to be done, would be general weight loss and an anti-inflammatory diet. So some recommendations for physical therapy would be patient education is a big piece. It's important to validate the symptoms of these patients. Oftentimes they've been, I don't want to use the word neglected, but they don't feel like they've been validated as far as their symptoms being real. And also to build trust with them. You want to educate them on proper posture and proper joint alignment, not only at home, but in their school or work environments. Talk about sleeping postures and proper support of all hypermobile areas. Pain management with self-care is also very important. Teaching your patient relaxation techniques, self-care with modalities like ice, heat, and TENS. And then your other tools that you use for chronic pain, such as desensitization techniques, mirror box therapy, graded motor imagery. And then when needed, refer out to the cognitive behavioral therapist to help you in this area. Manual therapy does actually play a role with hypermobile patients. It's important to remember to not overmobilize these patients. In fact, your goal should be to relieve any muscle spasm or trigger points or fascial adhesions. And then also working with the patient to reduce any subluxations and improve joint tracking. Stabilization is a key component for your treatment. Getting the patient to activate their stabilizers is very important. And I like the term ready, set, go. So teaching your patient to focus on their posture and their joint positions is the ready. The set would be to activate any stabilizers, and the go would be then to perform the movement. When it comes to strengthening, it's very important to do no harm. Proceed with caution. This is one way that you will either build trust or destroy trust with your patients, so it's very important to proceed slowly with this. Consider proper programming, always doing an adequate warm-up and cool-down. There was an article by Tinkle in Best Practices and Research in Clinical Rheumatology, and they found that isometric and low-load resistant exercises appear to be a good approach for this population. However, they also note that there's not a lot of research on any high-load resistant exercises or evidence of that being helpful. So that hasn't been ruled in or ruled out. But if you're looking for a place to start with the low-load isometrics. And then proprioception training. So start with easier activities. Use tactile and verbal cues, and also visual cues. Use more support. So maybe you have the patient up against a wall or a chair or near a counter. And then as you build up more strength and they build up trust as well, providing less external feedback and less support as you give them more challenging exercises. So stretching, should it be done? That is often a big question. But hypermobile patients can still have tight structures. So isolate the tight structure only, focus on the proper alignment, and proceed gently with these patients. A good example of this would be a patient with knee pain who has tight hamstrings. So, it's important to stretch those hamstrings. At the same time, you're strengthening the quadriceps and you're improving muscular balance and control, and then hopefully with also decreasing pain. So some factors to consider when you're programming your treatment. Biopsychosocial approach is always important. Tailor it to the patient and their specific needs. Remember, these patients often have had negative experience with exercise or maybe even in physical therapy. So building that trust is important. And then they most likely also have abnormal pain processing. So taking the time to address that and working through that. Remember that they have decreased tolerance to exercise and oftentimes different functional positions. So you'll need to find out what level they're at and then build from there. And they're often dealing with other comorbidities. So if you can address those or at least be mindful of that. So this is a nice slide. It's a basic principle of exercise progression, but I feel like it works really well with this population. First we got to promote tissue healing as we move to mobility, and then stabilization is key. And then if you think about, this is where maybe your athletes come in, where you're then moving to performance improvement, and then advanced skills such as agility and coordination. I found this to be interesting. This is an article from Britton and Flanagan in 2023. It was a systematic literature review of articles published between the years 2000 and 2023. And they decided to do this research project because there is limited evidence-based PT intervention research for this population. And they did find, after reviewing all these articles, that the strongest evidence for PT intervention was therapeutic exercise and motor functioning training, and less evidence for adaptive equipment, patient instruction, manual therapy, and functional training. They did note, however, though, just more research needs to be done in these areas. It's not necessarily that they don't play a role in treating your patient, but more research needs to be done in these areas. They did mention that in every article that they reviewed, it was recommended that that as you approach the patient, you look at the patient in a holistic approach, and you involve the interdisciplinary care teams. So, hypermobility in sports. Hypermobile individuals may be naturally attracted to certain sports that required increased flexibility or certain movements because those movements are easier to them. So think of the gymnast or the dancer. But again, when working with these patients, it's important to focus on strength and stabilization control, and then you build up the agility, speed, power, and accuracy. And then you also want to support the athlete, the symptomatic athlete, in other ways, so giving them anti-inflammatory guidance, hydration, talking about nutrition and recovery, and then using tape and bracing if it can be helpful in supporting any hypermobile area. So not a lot of research has been done specifically on the hypermobile athlete. It was kind of hard to find some good articles on this, but it is important to note that these patients will often, especially children, will often try to avoid PE and maybe even getting involved in sports because of their pain or their hypermobility and their weakness. So, working with the patient or even the family, getting them involved to find out what they're interested in and trying to find something that they can do so that they can have that good quality of life, but also maintain their strength, because these patients are awful fearful that they're going to have more pain or more issues after participating in sports. So one article I did find from Nathan et al. In 2018 on hypermobility and sport injury, they concluded the following regarding sports. They found that hypermobility has been found to be a protective factor in sustaining muscle or joint strain in all sports. However, this population also may sustain more severe injuries. And in the study, they found that joint dislocations were only found in the hypermobile group, and that these patients did require a longer recovery time compared to the non-hypermobile athlete. So in conclusion, there's many special considerations to have when treating the hypermobile patient and athlete. And in order to be successful, it's important that you keep in mind that they may require a longer rehab time. Teaching them self-management is key, and that each your approach to each patient should be different based on their personal needs. Thank you.